everyone. Welcome to the Prince Takamoto Japan Center webinar series, Aging Society in the Era of Pandemics, Approaches in Japan and Canada. I'm your host, Chelsea Mia, and today we'll be discussing seniors' life and care during COVID-19. I'd like to thank the organizers, Dr. Aya Fujiwara, Director of the Prince Takamoto Japan Center, and Mr. Shigenobu Kobayashi, Calgary's Consul General of Japan.
Good morning and good afternoon, maybe good evening. Welcome to this second webinar hosted by the Prince Takamoto Japan Center for Education and Research. First, I would like to say thank you for the Prince Takamoto Center for organizing this timely conference. And also the main speakers, Dr. Reiko Hayashi, just mentioned that Deputy Director General of the National Institute of Population and Social Security Research, IPSS, from Japan. From Canada, Dr. Jasneet Parmar. Within the larger picture of the aging society in the year of the pandemic, today we are focusing on the senior life and care during COVID-19. Today's topic is very interesting. In this year of this kind of the very difficult time of the COVID-19, right now there are over 300,000 infected people, PCR positive in Canada, and 13 people in Japan. Many of the people who passed away are seniors. So in this respect, the seniors' life and care is very critical in COVID-19. And more importantly, we are approaching the aging society. Many people who construct the country, region, they became elderly people. And some of them are physically or mentally overlooked or forgotten. In this respect, today's discussion will empower us to develop the crisis management mentality that is very difficult and sensitive. And personally, I am myself is getting old, and you may be called I am one of the senior. So in this respect, I think I personally very interesting. And once again, I would like to say, because of this situation, most of the listeners, you may be young, but today young, maybe tomorrow the old seniors. So this is a national agenda. So in that respect, I should follow today's discussion very carefully. Organizer and the speaker, thank you very much for your contribution today. Thank you.
Thank you, Consul General. I think next we'll hear from Aya.
Thank you very much, Chelsea and Consul General Kobayashi, and welcome everyone to our webinar series. I'm very pleased to host this timely event this evening. Since its establishment, Prince Takamoto Japan Center for Teaching and Research at the University of Alberta has been committed to the promotion of intellectual exchanges between Japan and Canada. The current situation has made it difficult for us to interact in person and encourage student mobility between the two nations, which are significant parts of our academic mandate. But we are hoping to continue such engagement through webinars, sharing our ideas internationally through webinars in this critical time. I appreciate the Consul General of Japan in Calgary for its invaluable support, and I'm always very lucky to have consistent opportunity to discuss with the members of the Consul General of Japan in Calgary's office, brainstorming what we can do together to bridge Canada with Japan during the pandemic. In both Canada and Japan, as Consul General said, COVID-19 cases are rising, and the two guest speakers, Dr. Hayashi and Dr. Parmar, will focus on the issue of seniors and caregivers, which has been one of the biggest challenges in the current situation. Thank you very much both for joining us despite your very busy schedule. I hope everybody will have fun in this talk.
Thank you again for reminding us of how very relevant and important this topic is. And I'd also like to welcome our guest speakers, Dr. Reiko Hayashi and Dr. Jasneet Parmar. I'm really interested to hear from both of our speakers. First, we'll be hearing from Dr. Hayashi. Dr. Hayashi is Deputy Director General of Japan's National Institute of Population and Social Security Research. Prior to joining IPSS in 2012, she served in Senegal as Technical Advisor to the Minister of Health As an expert on the development of community health workers and the Project for Development of Human Resources in Health, and was engaged in other projects concerning population and health in various countries. Her research covers global population aging, health and longevity, and population development. She holds a PhD in policy studies from the National Graduate Institute for Policy Studies in Japan. Welcome, Dr. Hayashi.
Today, I'm going to talk the overview of what's happening in Japan for the older person, how the COVID-19 affected them. This is the overview of the comparison between Canada and Japan. There are 4 lines. One is accumulated cases and the other accumulated death. And then this is the daily cases. And then this is the daily death. And then this is by the logarithmic scale. So you don't see the difference so much, but Canada have a kind of 10 times more cases and deaths. And also when we compare the curve, then in Canada there were 2 waves, but in Japan there were 3 waves. So now we are entering to the winter and the temperature is getting lower and lower, and then we are having more and more cases, and the number of deaths is increasing. So we are just trying to face to the new challenges. So what I might say, basically what has been happening up to the second wave. This is the age and sex structure of death in Japan. As you can see, there are a lot of men, more men than women. The most number is happening in the 80s. So this is how people have to be careful about COVID-19 for the older persons. When you calculate, for example, the proportion of elderly people and the mortality rate or fatality rate of COVID-19, there is a kind of correlations. Population aging is aggravating the COVID-19 influence. However, Japan is very aged society. So right now, the proportion 65 plus is 28%, 29%. And then if we count more than 60, then 1/3 of the people are aged more than 60. Because we have a lot of aged people, and then normally there are high mortality among the aged people. So although the life expectancy is becoming longer and longer, like here, the green line, the number of deaths is increasing a lot year by year. For example, last year in 2019, there were 1.38 million people who passed away. When there are many people who are passing away, what is the impact of COVID-19? This is what is happening this year. Monthly, we have the number of deaths, the total death, including COVID-19. However, compared to last year, most of the months, we have less number of deaths in Japan. We have to think about this effect of increasing number of older people. And this dotted line is the projected estimated number of deaths, considering this increase of old people. And then when we see this red line, this is the monthly number of deaths this year. It is much below. So actually what happened is that because of COVID-19, many people pay attention. Everybody wearing masks, everybody try not to visit so many people, everybody not to go to pubs and parties. It has impacted in the way that there are much less deaths compared to usual years. When we see by the cause of death, we can see that there is a lot of decrease in pneumonia death and also heart diseases. There is a slight increase of senility death. The latest statistic in June, there is a slight increase of disease of liver and diabetes. So this is a kind of worrying thing. And what has happened, firstly, to the healthcare access, the number of people going to the hospital decreased. It's decreased since January here, and it has decreased because people think that if you go, then you might have some chance to get the COVID-19 in the hospitals. Also, during May, there is a sharp drop for the outpatient, inpatient, because during the time, the hospital was very busy and they tried to tell people not to come to hospital if it is not very urgent. But this effect of COVID-19 just returned to normal in June and July. However, the number of outpatient, inpatient is not as high as last year. So this thing just tells us that this might give us a long-term adverse effect, that those people who are having chronic disease, they stop going to the hospital and they're not properly receiving the medical care. Or before, are we going to the hospital too often where there is no need because it is covered by the health insurance, and then people pay less. And then many older people are having time to go to hospital and so on and so forth. So this just gives us a kind of thing which we can think about. When we see the total use of long-term care, actually there is a monthly statistics, and then there is a kind of decrease during the month of January, February, March. However, this kind of trend is the same as last year. As the total use of long-term care, maybe it is not affected. A little bit influence was found in the visiting centers. For example, old people visiting to the daycare center and they do the daily rehabilitation, or sometimes they receive bathing service and so on and so forth. This kind of activities, or the caregivers visiting to the house, this kind of not facility-based services, there is a kind of decline, but compared to the decline in the decline of outpatient and inpatient, the decline was little. And then also during the month of July, this decline returned. So normally right now, our visit to the facility is limited. However, for those people who want to receive the care, they can receive the care right now. Already many people have talked about the proportion of death happened in long-term care facility. In Japan, it was 14%. This is up to May 2020, and which is much less compared to 49% in France, 47% in Sweden, or 45% in the US. I don't know what is this proportion in Canada. I would like to hear about this. And then what is the secret of Japanese low proportion of death in the facility? Maybe there is an early alert among the facility staff. And then now, even now, the family members are not allowed to visit the older families living in the facility. But in the normal time, for example, up in last year, only 12% of total death occurred in facility. And then compared to US, for example, 27% of death is happening in the facility and nursing home, long-term care facility, and hospices. In US, it is in 2018. So maybe this basic place of death in the usual year might be causing the differences during the time of COVID-19. And also, long-term care facility is important place for the place of old people in Japan, but the old people who are not receiving long-term care is also increasing a lot. This is a kind of chart that the total number of older people aged 65 and plus, it is increasing, and this red color is those people who are receiving long-term care. It is increasing, but there are a lot of people who are not receiving long-term care, a lot of elderly people who are active, who are healthy. And what they do during the COVID-19, actually 30% of the older people, their life does not change. Even the young people, they do not change their life. 25% of people here, old people as well as younger people, the first thing they do, they clean home. They throw garbages. And then secondly, they watch internet. And then old people tends to watch TV. And then also they do gardening and do it yourself. So that life has changed. 70% of people have changed, and then they do different things. Also, what the Japanese Geriatric Society is saying, that there is a problem depression, but more than depression, the problem or the risk is that the older people staying at home without exercise, without meeting people, that might cause the frailty. People do not talk, and then people do not move their mouths. People do not walk, so people muscle and then the articulation is becoming stiff. So this kind of promotion, practice promotion, talking with people promotion is now being done in Japan. For the poverty, many people are thinking that because of loss of job, the level of poverty is increasing, but this time, because of massive fiscal policies, in the beginning, the government paid 100,000 yen for everybody. The effect on the poverty level so far is not aggravating as much as during the time of the global financial crisis in 2009. And this is the same thing for old people. What has been biggest effect to our society is that we have been increasing the number of foreigners coming to Japan, but all of a sudden we have to stop incoming and outgoing international trips. As you can see, it has increased. Monthly, we are receiving something like 2.7 million people. There is a shoot, 5,000 people, as little as 1955. So we were planning to receive a lot of caregivers, foreign caregivers, but now we have to stop it. So what's going to happen? Well, now this is the time that we have to wait, and we have to see the situation without foreigners. This is the end of my talk. Thank you.
Thank you so much, Reiko. It's really fascinating to think about the challenges that Japan faces as a country that has a particularly older population, I believe the oldest in the world. And as we move on in the series, it'll be really interesting to compare our two systems and think about what we can learn from each other. So next, I'm going to be turning to Dr. Jasneet Parmar. Dr. Jasneet Parmar has 27 years experience as an academic, educator, clinician, and advocate in seniors care in the Edmonton Zone. She is an associate professor at the Department of Family Medicine at the University of Alberta and the medical lead of Alberta Health Services, Edmonton Home Living and Transitions. Dr. Jasneet Parmar, I have so many questions for you. The first one is, I think, about how the pandemic seems to have brought an already existing crisis to the fore. So I want to ask you about the chief challenges that Canada faces in terms of its aging population and why these issues have gone ignored for so long.
Thank you, Chelsea. And I also want to thank for being invited to this session. It's a real honor for me. I'm just going to take a few minutes to talk about seniors care prior to the pandemic. So Canada has an aging population like the rest of the world. And for the first time in Canada, we have more people over the age of 65 than we have under 16. And aging has been considered a triumph of the last century. As Dr. Hayashi said, people are aging well, they're living longer, and they're aging well. However, the number of older adults with chronic conditions is also growing, which over the last few decades led to increasing acute care demand for a number of reasons, but primarily because we did not do much in the way of investing in the community to provide the care that could have been provided in the community and avoid unnecessary or avoidable emergency room visits, avoidable hospital admissions. Older adults ended up in emergency rooms and in acute care. And that kept driving up the demand and also the costs to the healthcare system. Long-term care was seen as an answer to the solution. So there was increasing demand to have more investment made in long-term care. This allowed acute care to then move the seniors who no longer needed to be in hospital, however, couldn't be sent home because there wasn't appropriate supports in the community. This allowed them to move them into long-term care settings. So as the population aged and this demand grew, there was more and more investment in long-term care in Canada across all provinces. What Canada did not do very well is invest in community care simultaneously. So majority of the healthcare costs are absorbed by the acute care system, and that need continues to grow exponentially because there's all kinds of infrastructure costs as well as new technologies, super specialities, the need for elective surgeries, the need for also caring for seniors when they needed it for acute reasons. So overall, Canada did not invest very much in seniors' care overall compared to other countries in OECD. And of that investment that they made in seniors' care, majority of it, close to 90% went into long-term care and only about 10% went into the community. So when we look at people over the age of 65 needing care, we are looking at about 13%. 1/3 of them reside in long-term care and 2/3 are in the community. However, what you have to look at is the aging demographic. When people are around and over the age of 80, close to 50% are in long-term care. Now let's look at long-term care for a moment. So long-term care in Canada is not included under the Canada Health Act. The systems of care, the policies, practices vary from province to province, as does quality of care, as does access to long-term care. Long-term care was actually mainly seen as a housing option. People go there to live and to die. It really was not seen as an alternative to hospital care or care that would be provided for people who were medically complex and were on that trajectory where they had increasing health problems. Keeping in mind that it was designed for housing, the staffing ratios were at a minimum. 80% of the staff, by and large, are healthcare attendants in long-term care. Now, the education and the competencies of healthcare aides, as well as the length of their training, is increasing. However, by and large, a majority of the healthcare aides that are currently working have a certain degree of training, fairly limited in their scopes of practice, are being paid low wages. Often, again, to save costs, long-term care centers tend to hire more part-time workers because that means you pay out less benefits, there's less sick time, less healthcare benefits. What resulted was that these very hardworking people providing majority of the care ended up working on multiple sites to make a living. Staff recruitment and retention was a problem. If these staff found they continued down the path of skill training and education, moved on to better paying jobs, we ended up in a long-term care system where we were housing the most vulnerable population with considerable complexity and frailty being cared largely by healthcare attendants. And of course, it's not to say that we had LPNs and RNs and physicians and interdisciplinary staff as well. 20% of the staff comes from that pool, managers, etc. Very dedicated, very experienced people. However, the ratios of that staff to what the people in their care needed was very low. Now let's see what was happening in the community. So here we are, designing long-term care centers, variable practices, variable policies, etc., and housing seniors, frail and complex. And in the community, we have very little in the way of investing to care for this cohort of seniors. So seniors who are aging well, they have access to primary care, they have access to other healthcare systems that provide for them and are served reasonably well. But this cohort, who's the most vulnerable and most needy, had very little in the way of support. So for example, primary care for such aging older adults wasn't designed to care for them. We have great difficulty in providing primary care to the very, very complex, the very old and the very frail seniors. The numbers of seniors who were becoming housebound was increasing. But we did very little again to look to see how are we going to care for these seniors who have now become housebound. There was minimum investment being done in the one arm of the healthcare system, which is home care in the community. And I work in the community, I work with home care. I'm very proud of what they do. They have taken on the most complex, most frail. You cannot be on home care till you have these high needs. They have high functional needs. They have considerable medical needs, almost all the long-term supportive people on long-term care, as well as a significant number of maintenance, people requiring maintenance, and definitely those who are at end of life have very high needs. And the investment in home care fluctuates. So there are times there'll be more money available, we'll go out and try to do more. And then when there are budget cuts for some reason, this arm in the community doesn't get the same priority as the other streams in our healthcare system, and often suffers from budget cuts. This was the context of seniors' care. Aging population, increasing numbers needing more support from the healthcare system, increasing acute care demand, increasing seniors being moved to long-term care facilities, and very little being done in supporting, particularly the medical complexity in the community. And also the other services tended to be underfunded. Now comes the pandemic. What happens? Well, right off the bat, we need to create acute care capacity, because the modeling was that we are going to need all these acute care beds. Well, initially, as you know, with wave one, the modeling did not stand the test of time. And we were successful in bending the curve to some extent. However, what that resulted in was people being sent home from acute care. Majority of people in acute care systems now tend to be the older people, other than certain areas which are designed for younger populations, women's health, etc. So definitely there are some areas, but majority of acute care is caring for older people. So there was this big drive to move for two reasons. One, to create that acute care capacity, as well as congregate settings, regardless of where they were, was seen to be a high risk for seniors. So they were discharged home. And the general messaging was, we are going to avoid acute care if possible, avoid going to emergency room if possible. It led to this general decanting of seniors from acute care, as well as emergency room avoidance, which Dr. Hayashi also talked about. Some of it was because the seniors themselves felt at risk. Some of them came home willingly, and some of them don't go to emergency room because of the fear of catching the infection. But what happened along with this, which is so unfortunate, was there was a reduction of the services. Already we don't provide much, and then the services we were providing were pulled back. Why? To prevent the spread of the disease. So with good intentions, none of this, as you can see, has been deliberate or ill-intended. But what happened was, now you've suddenly got a huge cohort of seniors in the community who don't access acute care, avoid emergency room for different reasons, or they're not welcome there. We are trying not to move them into long-term care, so we are leaving them at home, but at the same time, we reduce services. And what have we done in the process? One, there's been decompensation of seniors' health in the community, as well as we've shifted the care onto the family caregivers. What's happened in long-term care? It became the center of epidemic in Canada. We have seniors, the most vulnerable in congregate setting with a virus that spreads like wildfire. And then we have staffing who are moving in and out, multiple sites, often not taking time off work because they don't have sick leave or the benefits, worried about their salaries, etc. And also there were many other reasons. The testing and tracing practices varied, the PPE access varied. All that has improved now over time. Another fact which most people don't talk about is that prior to the pandemic, we know from evidence that family caregivers provided anywhere from 10 to 30% of the labor in long-term care. They actually provided care for residents in long-term care. I was one of them. I cared for my dad willingly. And I could see the difference it made in his care and the difference it made for the staff looking after dad. So having pulled that labor, suddenly now the staff are expected to pick up that care. And I'll briefly talk about the general state of what's happening with family caregiving in Canada. And we've done some research recently, which speaks to it as well. So we know pre-pandemic, family caregivers are providing anywhere from 70 to 90% of care in the community. They are considered the backbone of our healthcare system and our society. They provide all kinds of support. We know that, and we need them to sustain care. The pandemic created two solitudes of family caregiving. So family caregivers who were at home became overwhelmed with care. And this is a survey we did this summer. It was once again validated by a survey that came out of UK in October, which showed similar findings. So solitude one is caregivers being overwhelmed with care in the community, particularly when they lived in private homes with the care receivers, with the older adults. They ended up taking on a lot more care because the older adults' health deteriorated, decompensated, so they had more needs, and the community-based resources to caregivers, to the seniors and to the caregivers were reduced. The other solitude that's also worth mentioning is being excluded from care in long-term care settings. These caregivers, once again, suffered because they were not allowed to care. So it's not just the healthcare system suffering and the care receivers not getting the attention they need, the residents not getting the attention they need, but these family caregivers were suffering as well because they were being excluded from care and they were worried and anxious. And what our survey showed, as well as this survey, it's called Behind Closed Doors from UK, the mental and physical health of family caregivers deteriorated. Their anxiety and loneliness went up significantly. And significant numbers reported exhaustion from caring, and significant numbers reported being close to burnout. So we have to pay attention to these, what I'd like to think, care partners in providing care for the seniors. So the question then is, what is the answer? So we absolutely need federal and provincial policies and strategic planning that supports caring for older adults in the community and provides support to family caregivers, which not only sustains care, but also helps the family caregivers maintain their own health and well-being. There has to be incentives for people to stay on in the community, as well as we have to think of different models of care which gives our older adults and their caregivers control over their care. We've got to give them a real choice to stay in the community. We have to examine how are we providing primary care to these very medically complex people if we are going to support them in the community. And the thresholds to enter long-term care have to be examined. There has to be evolution of home care to expand its role and scope, and the community organizations that have taken on a lot of providing support to the family caregivers have to come together with the healthcare system and coordinate and collaborate, providing supports. So there needs to be a deliberate attempt made at how do we bring these social and healthcare systems of care together to wrap services around older adults and their caregivers who are in need of care.
Thank you so much, Jasneet. There's an interesting comment from the chat. Carmen points out it's not a new problem. There have been problems in the home care system for many years. It's only now with the pandemic that we have that reality in our face. And I think that's really true. And some of what you've done here, or what you've both been doing, is sort of pulling back the blinders and showing how in Canada, it feels very much like a pressure cooker. I know when we, myself and others, saw the footage back in the spring of the military being called into Quebec and Ontario to help out, it felt very shocking. But I imagine for people who are on the front lines and workers and experts in elderly care, it was maybe not as shocking as it was for the rest of us. And I liked the point that you made as well about that need to invest and that sort of lack of investment that's been happening in Canada. So I wanted to ask Dr. Reiko Hayashi, how has Japan kind of approached this problem differently? As you mentioned, Japan has the world's oldest population, almost 30% over the age of 65. Dr. Hayashi, in the past, who would be traditionally responsible for taking care of seniors, and how have the attitudes and approaches to elder care changed in Japan in recent times? And I'm thinking here in particular of the mandatory long-term care insurance program that Japan introduced, but I'm sure you have other ideas about how things have changed.
That's a big question. I was surprised that in Alberta, 72% of death is happening in the facility. That shocked me. I think that maybe because your facility is a place of cluster. One difference between Japan and Alberta, then maybe we have this cluster-based approach. So once you find one person, then you trace everybody around this person who are infected, and then try to stop the further infection. This kind of approach, I wonder if in Alberta you are taking this kind of approach. If not, the facility will be the best place to propagate for the COVID-19. Dr. Palmer was saying that in Alberta, are you going to promote home care instead of facility care? Hearing what Dr. Palmer was saying, I thought that maybe the basic system of provision of long-term care is very different. What happened in Japan is in 2000, we have introduced the long-term care insurance. Everybody aged over 40 pays the insurance premium. However, half of the cost of long-term care is provided by the national and prefectural and municipal government. Actually, 1/4 is by national government, and then 1/4 is by local governments. Because we have started this long-term care insurance, the long-term care has become a big industry because the safe financial base. There is a guidelines for the good services, and also there is the payment. So although we are lacking a lot of caregivers, the qualified long-term care personnel, however, the number of those people who are engaged in long-term care services just increased. It has something like it has tripled, 4 times more than before 2000. Because we have this basic framework of long-term care, this has just assured the proper, somebody just mentioned that maybe there is a difference of disinfection in the facility and so on. All of these basic services is done everywhere in Japan. That might be what we are having right now. Who give the care? Yes, of course, 70% of the older people who need care are cared by the family member. The family member is the primary caregiver and assisted by the public services. Among 60 or 70% of family caregiver, they are women, but increasing men. What happened is that since we have introduced long-term care insurance, before the long-term care was the task of the wife of the elderly son. And then in the past, in the 20th century, we have this family notion, and then it is an obligation of family to take care of the older people. And then obligation comes to the wife. One of the reasons of introduction of this long-term care is to stop this kind of family obligation, just bringing this family thing to the social sphere. At the time, there is the discussion that whether we should pay the family caregiver the money out of from this insurance fund. And then it is the Women's Association, Women's NGO, who said no for that. If we pay for the caregiver at house in the family, then that will give a tacit pressure so that they have to stay at home. Because you are receiving money, you, the woman, should stay at home. This is something which has been changed since the introduction.
That's so interesting, Dr. Hayashi, how this insurance program actually helped combat some of that inequality in terms of the burden of care and how that was sort of traditionally placed on women. That's really interesting. I'm wondering the challenges that caretakers face and how the pandemic has shifted the family dynamic. How have Canadians and people in Japan seen their living situations and the roles of caretakers change?
Prior to the pandemic, approximately 25% of Canadians were providing family caregiving, and they were providing a wide array of supports, anywhere from providing support, functional supports for basic activities, instrumental activities of daily living, to financial support, considerable financial support, emotional support, And what often gets overlooked is actually support for healthcare related needs. So it's to do with monitoring signs and symptoms and managing crisis and advocating for the older adults. Already we knew in Canada that the family caregivers were, and it's not caregiving. I know there's a comment in the chat box. As a society in Canada, we actually believe in family caregiving. We believe it is our responsibility. And most caregivers also report the positive aspects of caregiving and report caregiving being satisfying and fulfilling, and they see it as part of their duty and reciprocity. But what we have to realize is that load of care. So when that increases in intensity or when it extends over a long period of time, that we start to see signs of negative consequences of caregiving. So we were already starting to see significant numbers of caregivers who had this increasing care intensity and increasing duration, as well as providing care to more than one care person, having caregiver stress, burnout, decline in mental health, physical health, and leaving work, reducing work hours, affecting our economic engine when it came to providing labor in the labor force. So there were many consequences that were happening, and they're often called the hidden patient. Care for them, they actually do become the patient. They were having difficulty sustaining care. And we had the opportunity in the last decade, having recognized that many researchers doing great work and informing us to actually start supporting them, not just to sustain care, but also for their health and well-being. Well, then came the pandemic. And we have, from our survey, 73% of family caregivers here in Alberta saying they're providing more care if they're living in private homes, and close to 60% if they're living separately. The additional hours of care went up exponentially. So 68% added anywhere from 11 to 40 plus hours a week in the same home. And close to 40% added 11 to 40 hours a week when caring from a separate home. Absolutely, there's been consequences, particularly for family caregivers in the community. But what is interesting to note is that the mental health, the anxiety and loneliness increased for both solitudes of caring, the ones caring in the community and the ones that were excluded from care in long-term care. 86% of our family caregivers in our survey identified loneliness on a validated scale.
In the beginning, there is this kind of reduction of visit-based service, either the caregivers coming to the home or the old person who need care go to the service centers. At the time, there is an increasing burden for family caregiver. During the time, there is a hard time, but right now, this has became normal. I think that the basic severity of COVID-19 is very different from Japan and Canada or Asia and Western countries. The other day, we are having the webinar together with a person from Taiwan who is a specialist of long-term care in Taiwan, and he was saying that there is no change at all in the long-term care setting. I was surprised. On the contrary, for example, facility, as I said, the family are not allowed to visit. So still this shut-out thing is continuing. That has changed a kind of relationship with the family who are in the facility and who are living outside. And also before, I see many daughters or many of my friends who are visiting their parents who are living very far away. You see, taking plane and going to take care of them once a week or once a month. They stopped it. So for sure that have reduced the family relationship. But on the other hand, also I hear there are many elderly who were given the mobile phone, and then they start communicating through, we use Line application, which you can chat and you can see faces. This is the change. maybe I should say.
Thank you. That's really interesting. In Japan, they were offering any different approaches to help keep families in contact and combat those feelings of loneliness. And I'd like to ask Jasneet as well, how do we strike that balance between keeping seniors safe from infection while also protecting them from the harmful effects of isolation? Some doctors mentioned this confinement syndrome of depression and cognitive decline that can happen when seniors are not seeing visitors and not having activities. So how do we strike that balance?
That's the $1 million question, right, Chelsea? So as I said, this isn't ill-intended, right? This has happened because we are trying to also protect the seniors from getting infected, that trying to keep them at home. We reduce the footprint of the healthcare staff in their homes, prevent admissions into long-term care, and also the visitor restrictions are for that purpose, right? But there are all kinds of negative consequences because of these public health precautions. So how do we strike the balance? Already, and I want to end on a positive note, not that I want to minimize the criticality of the situation, but both federally in Canada and every province is looking at how do we care for our older adults, not just during the pandemic, but also beyond. Almost everyone is looking to strategize around how do we increase the care in the community. There is evolution of home care supports being examined by most of the provinces. Because we finally shed the light on family caregivers. So if the pandemic has done one good thing for us is to shed the light on the importance of family caregivers. And now we are looking at the role of family caregivers, not only in the community, but also in long-term care. So federally, there is cost-sharing programs going on. Provincially, governments are supporting long-term care centers, both with costs as well as some of the provinces are taking the staff on as their employees, bringing in more consistent contact tracing, public health precautions. And very importantly, what they're doing is they're allowing family caregivers to go back into the long-term care centers. They're examining the role, but they're making sure of two things. One, that these are actually family caregivers, not visitors. They actually will go in and provide, they have a role to play in caring. And two, making sure that the caregivers coming in follow public health precautions.
Jasneet mentioned how we're taking a slightly different approach now when we're in the second wave than back in the spring. In Japan, has your approach changed now in your third wave? Are there things that Japan will take from this and will do differently?
Approach has been changed a lot because in the first wave, we have this state of emergency declaration, and then we tried to shut everything. And then after that, we realized that our economy has been affected so much. Although we are having a lot of cases, but still, we are slow in closing all the economic activities. You see, every day we are having the new situation. And then so far it was okay. There were less death compared to last year, but in the future we might have it again. So every day we have to judge the situation. I have some questions saying that, is it the case of public or in Japan and Canada, private? The basic structure of long-term care services is so different. It's a good time that we can analyze how the different systems turn out to the different consequences. In case of Japan, the insurance is public. There are also the private care providers. Private care providers are providing the long-term care services, and there are some money coming from the public long-term care insurance. It's a very complicated system, but so that we can combine all the participants. And then regarding the community, I didn't mention this today up to now, but we have this community integrated care approach where private operators and then public operators and municipality government and all these people in the community, they create a kind of network so that they communicate each other to offer the best effective services for those elderly who need care. If this kind of care setting is changed by the COVID-19 or not, there are many meetings of this community integration. We have to stop the physical meetings, so it has changed. Now that we get accustomed with this COVID-19 situation, it seems since February, it's almost 10 months So we are trying to do the best.
Yeah, almost 10 months, right? And as you say, there are so many new developments. It seems like every single day is bringing new changes and new things that we have to contend with. So just to conclude briefly, we've had some really great news the past week in terms of vaccine development, and we're all, of course, really hopeful that these vaccines are going to bring an end to the pandemic. But the question remains of how to better take care of our aging population, and this is one that's going to be ongoing. Final question to both of you is, how do we ensure that we don't forget about these issues after the pandemic ends?
I'm hoping that this experience is significant enough. It will result in positive action and that it will not be forgotten. This is a catastrophe of major proportions. And usually such catastrophic events become tipping points. They become the reasons for change. And I think that change is happening. We will continue down this path. This was the watershed moment. There is so much attention being paid. And we also know that this is not the only time we are going to be hit by a virus like this. There are other pandemics coming down the road. So we need to be better prepared. So I think both as a society and as well as a responsive and a responsible government and healthcare system, we recognize that this change needs to happen and it needs to be sustained.
I completely agree with Jasneet that this is not the last pandemic. There will be another virus, the new virus coming here and there. Have to prepare. This COVID-19, we have never had such a big, massive lockdown thing. It might be the first thing in the human history that so many countries have closed the doors and so on and so forth. So as I said, that there are much less death. Why it happened? People are not going to the hospital, but they are not dying. How was our healthcare before? And long-term care, what was the necessity? And then now that we don't have the new incoming foreign caregivers, what's going to happen? And then couldn't we do without additional long-term care worker or not? So there are so many things which happen, which merits to be further analysis for the better systems for healthcare and long-term care, how society should behave. For example, now everybody wear masks. After the pandemic, are we going to remove our mask? Maybe some people will try to keep them our masks. So
thank you both, Dr. Reiko Hayashi and Dr. Jasneet Parmar, for joining us.
Thank you very much for a very interesting talk from two powerful and influential women. And I really learned a lot in terms of the differences and similarities between Canada and Japan in terms of family dynamics and finance and challenges and policies. And I really hope that, as you both said, this will lead to something positive in the future so that we could prepare, future pandemics. And thank you so much for being with us. And thank you very much, everybody, for joining us tonight.